Hello, my name is Brendan O'Farrell. I'm the president and founding partner of DCN Diagnostics.
And I'm Pat Vaughan. I'm the Chief Operating Officer here at DCN, and I run all our development programs. So, but obviously the conversation on testing at the moment, be it molecular, be it immuno-based, obviously some key, definitions that we come across are sensitivity. So sensitivity would be a way of defining how sensitive is the test. What's the test's ability to be able to detect the analyte that you're looking for? So if you know that you have 100 patient samples that are positive, then your sensitivity of your test is its ability to detect all 100 tests. So if you detect them all, it has 100% sensitivity. If it only detects 60%, it has a 60% sensitivity level, which obviously wouldn't be very good. Similarly for specificity. So you want it to come up positive when it's positive for the analyte that you want. If it comes up positive when really it's a negative, that's a false positive, and then that would mean a decreased sensitivity of the test. So it's not specific for the analyte that you want. So there's other cross-reacting species or whatever it is being detected.
Yeah, and the importance of those things can shift, right, depending on really a risk-benefit analysis. Taking the example of SARS-CoV-2, early in the outbreak, from the perspective of developing diagnostic tests, particularly protein-based diagnostics, the antibodies specific to CoV-2 were not available. However, antibodies that had some cross-reactivity with other respiratory infections, other coronaviruses, did exist and do exist. So it becomes a cost-benefit analysis to say, you know what, is it more important that we catch a positive and maybe have a few false positives, or do we miss that positive, right, and run the risk of having things spread that way? So in that scenario, it's allowable from a cost-benefit analysis to have an assay that cross-reacts a bit with other SARS species, right? So particularly because, there are probably no major incidences of other SARS viruses going on right now. So how you decide as to what represents acceptable clinical predictive value is based on a variety of things, and that risk benefit is one of them. And remember always that the diagnostic test is only part of the algorithm that relates to clinical predictive value, right? So you can get a diagnostic test result, but then that has to be matched with symptoms. It has to be matched with an understanding of the epidemiology, and the physicians can make a determination based on everything that goes into that algorithm. The test is one of those things.